Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfing, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends. I am so excited you are joining us for yet another week of Breast Cancer Conversations. What I love about our conversation each week is that we get to choose different topics and take deep dives in the important topics that you, our listeners, are really interested in. So I appreciate all of you sending me emails and following us on social media and giving us ideas and asking questions, which then enable us to go out and find the answers. In today's conversation, we are going to focus on the topic of metastatic triple-negative breast cancer and specifically a drug called Trodelvy. Today, I'm joined with Dr. Bardia, a Board Certified Medical Oncologist interested in developing successful targeted and personalized therapies to improve the outcomes of patients and families affected with breast cancer. Dr. Bardia is involved in clinical developments of tumor genotyping as well as circulating tumor cells to facilitate accurate diagnosis, therapy selection, and real-time monitoring of breast cancer. Dr. Bardia is the primary investigator of clinical trials investigating the role of targeted therapy combinations for breast cancer and is the recipient of the Young Investigator Award from ASCO Conquer Cancer Foundation. I am joined with two other amazing women, Janice and Keegan, both living with metastatic TNBC. Janice was diagnosed with stage 4 metastatic triple-negative breast cancer in 2016, a recurrence from stage 1 5 years prior. With a 20-plus year background in nursing, science, research, and studying disease, it is no surprise that Janice became an amazing patient advocate. Her advocacy work has included working with organizations like METAvivor, Living Beyond Breast Cancer, ABCD after breast cancer diagnosis, among many others. I am also so excited because I am joined with Keegan Hitchcock. Keegan is 41 years old, born and raised in Florida, where she had a professional career as a face and body painter for over 20 years. Her interests include reading, consuming lots of podcasts, including anything from spooky stories and humor to the lesser-known history, critical thinking, and science. She loves watching and discussing nerdy TV shows and movies with friends, roller skating, and spoiling her 2 cats. Keegan now lives in Maryland near family, where she continues to work at a national health food store doing price integrity. Her original diagnosis was in May of 2019 with stage 3 triple-negative invasive ductal carcinoma. As of April 2021, she's been diagnosed with a recurrence, stage 4 metastatic triple-negative breast cancer. I originally met Keegan through our Thursday Night Thrivers weekly meetup, and it's such a pleasure to have her here on today's podcast. What a stellar panel. I am so excited. Thank you all for being here. Welcome to the conversation. It's lovely to have 2 amazing patient advocates, thrivers, and women living with metastatic triple-negative breast cancer on our podcast, Breast Cancer Conversations today. Our stories really become the inspiration and provide hope for all of those people who maybe have been newly diagnosed, recently experienced metastasis, maybe they've been diagnosed de novo metastatic, maybe their cancer started off ER positive and it flipped to become triple negative. You know, all of these nuances, right? Like we're under this umbrella of breast cancer, and then within there are so many subgroups. So let's dive right into our panelist.
I'm Keegan Hitchcock. I am in Maryland currently, about 20 minutes from Washington, D.C. And I am currently going through treatment with Trodelvy. I was originally diagnosed triple negative stage 3 in May of 2019 and went through chemotherapy, bilateral mastectomy, radiation, and was, no evidence of disease, all clear, everything for about a year and 4 months, something like that. And then just doing routine. At that time, I was doing every 6-month PET scans. Started to feel a little bit of pain and something looked a little strange on one of the PET scans. It was either end of March, beginning of April this year. Yes, it has come back at stage 4, still triple negative. Started with Gemzar. We only did a couple rounds of that before realizing that maybe radiation would be better for me at the time. The spread was in the chest wall on the skin. And so did a pretty intense radiation for about 8 weeks, and that helped. But during that time, there was a spread to the bones. And so then As soon as I was able to, after radiation, we started the Trodelvy, and that is where I'm at now. I just completed cycle 4.
You touch upon a lot of topics that come up just in our conversations, right? People are always curious about what the signs and symptoms are. How do we know? There's a lot of anxiety around, scans and going in to see. I feel like I was reading a book recently, and this gentleman lived to be 103 years old. He mentioned that he never goes to the doctors. And he's never been sick because he's never been to the doctors. Right. And I just thought that was like the perfect mantra of, right, of course, we go to the doctors, and the more you look for something, the more you're going to find. So I definitely want to circle back with you on, maybe going into what the signs and symptoms were as you were describing some of the pain, maybe in more detail. But before we get there, I would love to ask Janice, I'm so glad to have you. You are not new to survivingbreastcancer.org. So it's nice to see you again as well. If you would like to introduce yourself and where you're calling from.
Absolutely. Thank you, Laura, for inviting me here today. My name is Janice Cowden, and I've been living with stage 4 metastatic triple-negative breast cancer since June of 2016. Mine was a recurrence from stage 1 triple-negative approximately 5 years prior to that. I had very limited metastases at diagnosis, and I was very fortunate to have had a complete response to my first line of treatment in 2016. And on my first scan, I was no evidence of disease. I have remained no evidence of disease and on no systemic treatment for 5 years this month, actually. Wow. So my response, I'm an exceptional responder, and the duration of response is very rare and very unique.
And shortly after your diagnosis, you got involved in Hear My Voice training through LBBC. Can you tell us a little bit about your background and what got you into patient advocacy?
My background's in nursing, although never worked in oncology, but I was a pediatric nurse for about 20 years and then did pharmaceutical sales for about 4 after that. So science has always been very important to me. I've always been passionate about educating patients, and now that has turned into a passion for educating other patients, but also educating the public about metastatic breast cancer. I have 2 primary areas that my advocacy has followed that I'm very, very passionate about. And one is research advocacy, and the other one is peer support.
Janice, that's amazing to be an exceptional responder. What hope and inspiration that gives to all of us. What was your line of treatment that you were on?
My first line of treatment was a chemotherapy combination of adriamycin and Cytoxan. Back in 2016, that was one of the standard of care protocols for metastatic triple-negative breast cancer. And of course, we didn't have immunotherapy at the time. As you know, triple-negative doesn't have any targets like estrogen and progesterone and HER2, so we don't have any maintenance therapy. And my oncologist and I had a discussion about continuing on with another treatment just as a maintenance type treatment for an additional 6 months. But we decided to just monitor through scans and surveillance and see what happened rather than exposing me to more toxic chemotherapy at the time.
Thank you, Janice, for sharing more in depth about your treatment plans and the maintenance or lack thereof that you're currently on. What incredible inspiration. I keep saying that because it really is truly remarkable. I am also here and happy to welcome Dr. Bardia, who is joining us today as the lead investigator on the ASCENT study. He also works in breast health and oncology out of Massachusetts General Hospital. Dr. Bardia, thank you for being here today.
Yeah, absolutely. Thank you for having me. It's my pleasure to be here today. I'm a breast medical oncologist, including patients with advanced metastatic disease. Over the years, we've been involved in developing new drugs as well as combinations for our patients. And that essentially is what drives me to come up with better options in terms of treatment options for our patients with breast cancer.
And how did you get involved with the ASCENT study? I think clinical trials are such an important part of the breast cancer community. We're always looking to, one, be part of the research, knowing that we're passing on the torch and helping those who come after us, but then also really being able to be part of groundbreaking studies and research and even learning more about our cells and our tumor cells. So I would love to hear a little bit about the development of this study and some of the findings.
Yeah, absolutely. I think this starts with talking about triple negative breast cancer. We know that patients who have triple negative breast cancer have an aggressive tumor biology, and at least in the metastatic refractory setting, some of the standard chemotherapy agents don't work that well. So clinically, there's been a big need to come up with better therapies for patients with triple negative breast cancer. If you look at the terminology of triple negative breast cancer, essentially it's defined as tumors that do not have estrogen, progesterone, or HER2 receptors. The point being that it's defined by something that the tumor does not have. But there are alterations in the tumor that drive it. And that was something that we were very interested in. Can we target an antigen? Can we target something that's present in triple negative breast cancer, something that's actually positive in triple negative breast cancer in terms of a target? And we saw that there's an antigen called TROP2, which tends to be overexpressed in triple negative breast cancer. And around that time, this is 2012, 2013, there was a drug being developed called IMU-132, which was the previous name of Trodelvy, which was an antibody drug conjugate against TROP2. The idea being that the antibody binds to TROP2, goes inside the cancer cell, and then delivers the payload or the toxic payload SN38 to the cancer cell. So it's what we call a smart bomb, a way of giving high doses of chemotherapy by tagging the cancer cell for something that it has and normal cells don't have. So coming back to what I was saying earlier in terms of finding a positive target in triple negative breast cancer. So we opened the phase 1, phase 2 trial in 2013. And the first 2 patients that we treated with this drug, we could see responses that we had not seen before with other agents. And also for those patients, they had a disease that was refractory to other treatments. So very early on, we knew that this was a drug that had activity in triple negative breast cancer. And that generated interest, excitement in our center. We were getting referrals from the region for patients who wanted to enroll in the study. And I would say many of them derive benefit. I distinctly remember the story of a patient who was young, enrolled in the trial. She was able to complete her PhD. She was able to get married. So was able to participate in important life events. And to me and to our team, that was success. And the results of the phase 1, phase 2 trial were quite promising. And that is what led to the ASCENT trial, which was the final confirmatory trial comparing IMU-132 or sacituzumab govitecan or Trodelvy, as we call now, was a standard chemotherapy. And we saw that in patients with metastatic triple negative breast cancer, the drug had a much better progression-free survival, overall survival as compared to standard chemotherapy. There was actually a doubling of overall survival in patients who received this drug versus standard chemotherapy. So it confirmed the initial observations that were seen, and we're thrilled that it's an option that's available for patients in the US. And I think about a month ago got approved in Europe as well.
That's outstanding. Such great news. I'm going to the San Antonio Breast Cancer Symposium in a couple of weeks. And I just love sitting in the audience and like literally every 15 minutes hearing the findings and the research and literally getting goosebumps when we have these breakthrough cases and the great work leading from phase 1, 2 to eventually get to phase 3. A couple of questions, if we can dig into a little bit of this study. I know some people were asking about the participants themselves, and we know that we're targeting metastatic triple negative breast cancer patients. I believe I was reading they have to be on their second line of treatment. Do I have that correct?
That's correct. So the ASCENT trial essentially was for patients with pre-treated metastatic triple negative breast cancer. So it required that patients have received prior lines of therapy. This was not a first-line trial. It did allow patients who had received chemotherapy without immunotherapy as first line. So if you look at the current management of metastatic triple negative breast cancer, usually the first line is chemo without immunotherapy. And then after that, in a patient who has disease progression, this is a good option, and that's consistent with the FDA label.
We know that within triple negative breast cancer, there could also be additional subtypes, such as inflammatory breast cancer or lobular breast cancer. Did the ASCENT study include any of those subtypes?
That's a good question in terms of the subtype of breast cancer, in terms of the histology and receptor. So we've looked at a number of biomarkers. The first, looking at patients who had originally ER positive disease and then over time became ER negative and were enrolled in the trial. In that subgroup also, we could see benefit. We also looked at biomarkers such as TROP2, which is the target of this agent, BRCA, and in all the subgroups, the benefit with this agent was higher than that of standard chemotherapy. And finally, we looked at age in patients who were more than 65 versus less than 65. And again, we could see benefit in both the groups. We still need to do more biomarker work looking at luminal A, B, basal subtype, the PAM50 subtype of triple negative breast cancer, as well as other biomarkers. So that work is ongoing. But at this time, it looks like all the subgroups derive benefit with this agent.
That's outstanding. So I'm sitting on this side just smiling. You can hear it in my voice. I would love to turn the conversation over to Janice briefly as we're talking about the ASCENT trial. I believe you had some involvement in helping shape some of the language to let people know about the trial and how they can get involved. Can you tell us a little bit about your work in that realm?
Sure. Thanks for the question, Laura. Initially, I was contacted by another patient advocate, Patty Spears, who's an early stage breast cancer survivor and a very well-known advocate for her expertise and work in the breast cancer space. And she asked if I would like to participate in a plain language summary of the ASCENT publication and to offer my perspective as someone who's living with metastatic triple negative breast cancer and connected to the NBC community through peer support groups. Also, she was well aware of my passion for research advocacy as well. And so this plain language summary, which was authored by Dr. Bardia and other ASCENT trial investigators, it was presented to me with the purpose of editing to ensure that it was understandable for readers of all knowledge levels using non-technical language. And to be honest, it was my first experience as a co-author on any type of paper, and I was really honored to contribute. I also provided a patient testimonial on the importance of clinical trial participation and in advancing science and leading to the FDA approval of new treatments such as Trodelvy, because treatment options are rather limited for this aggressive subtype. The more we participate in science, the quicker we'll get new treatments to help patients who have metastatic triple negative breast cancer. And plain language abstracts and publications are really important for patients to help them understand how treatments work, why a treatment may or may not be the right treatment for them. And as we all know, many patients do not have a science or healthcare background. So by putting scientific information into terms that anyone can understand is beneficial for patients, and it helps them to create a more effective dialogue with their healthcare providers. And I believe that it empowers them to advocate for themselves as well.
Keegan, let me turn things over to you as well. So you are someone who is living with metastatic triple negative breast cancer and are actually on your 4th round of Trodelvy. Can you tell us a little bit about how you and your oncologist decided this was a good opportunity for you and how you're doing on the treatment?
Sure, thanks. I just completed my 4th cycle. This was my off week. I'll begin my 5th cycle next week. We kind of decided, honestly, it was just kind of going through what options. And as I think both Dr. Bardia and Janice and you have mentioned, there's not always a lot of options for triple negative breast cancer, especially once you get to stage 4. We had tried for a little while doing gemcitabine at the very first sign of this recurrence. And I had some response to it, but it wasn't quite as great as we had hoped. And then, it wasn't unsuccessful, but that's when we switched over to do some radiation just to kind of, in lack of better words, just to kind of blast that particular recurrence out of there. And then instead of going back to see how the Gemzar went, I had issues with my platelet counts. They generally tend to be low for me. And so the Gemzar was kind of making that even lower. So rather than kind of play that game and waiting to see, if they go up and down, all this, My doctor and myself had both heard positive things about Trodelvy, and I had read, I think many of us once diagnosed, and then especially if we have a recurrence, we kind of dive into reading anything and everything that we can that might help us. And I had heard a lot about Trodelvy being, one of the newest and most promising treatments out there. And then it was, kind of novel in that it was, I believe it's not 100% immunotherapy. You experts correct me if that is not right, but that it is similar to, but not exactly immunotherapy, which is very new and different for triple negative. So because of that, and because of all of the studies and trials that had happened, we were like, this looks like it could be the best thing. So we gave that a try, and I've had good response so far. There was I think about it was either 2 or 3 weeks I had to take a break from it because of other difficulties I was having. And at that point, we were a little bit concerned because the next time they checked the tumor markers, they had gone up. And so we did do a scan, based on that, just double checking, like, okay, am I having progression? Is it failing? And it turns out with that scan, it looks like, no, it is not failing. I'm actually stable from the scans we got around the beginning. Nothing new has popped up. Nothing has necessarily shrunk or gone away at this point, fingers crossed. But my doctor seems pretty confident that it was just that break that kind of caused the change in the tumor markers. And so we are continuing on that. I'm excited to hear the word stable.
Yes, exactly.
And hoping that, it's okay, cool. That is the first little goal we've met. Now let's hope that the next one is, shrinking and getting rid of things. So that's kind of where I'm at right now, about to go into the 5th cycle. Like I mentioned, next week, there is a possibility. Janice was just mentioning how important it is to be involved in studies and trials. There is a trial semi in my area that I have said I'm interested in. So if accepted to that, I will have to take a break from the Trodelvy. But, that's all kind of up in the air. We're happy to be on the Trodelvy for now, unless or until a trial becomes available. But not because it's not working, just because, as you mentioned, it's always a good thing to be involved in those if you can.
Absolutely. And just for a moment of clarification for our listeners specifically, can you describe what the cycle is? What does the regimen look like week to week?
For me, the cycle means it is a 21-day period. And in each cycle, I have 2 infusions. So for me, my infusion days are Thursday. So on Thursday, I will get an infusion. Then the following Thursdays, that would be day 8, I will get another infusion. So that's IV, and I have a port. So we do a port. You go in, you get your pre-meds through your port. You get the IV treatment of the Trodelvy, which is a couple of hours. And then a week later, you get your second one. And the terminology is still hard for me. Sometimes I mix it up. So I believe the way that most people refer to it is the cycle is that whole 3-week period. Round is each infusion. So your first round is your first day. You get the IV infusion. And then, as I said, the following week on the same day. So Thursday, then next Thursday, I will get it again. And then the following Thursday, I get a week off to let my body kind of recuperate, let the numbers and counts come back up. And then you begin again, your next cycle, same process. So it's 2 weeks on, 1 week off. That is your cycle. And each infusion in that cycle are the rounds. So some people like to count how many weeks, how many cycles, how many rounds. It all just kind of depends on what works for you.
Yeah, well, you explained that perfectly. It's so complicated. I remember being overwhelmed when my oncologist was showing me different rounds and treatments that I was going to be on. And I was so overwhelmed by the diagnosis that mathematically I was like, wait, 2 or 4 weeks? Like, what are we talking about here?
Yeah.
So it could definitely be overwhelming. Dr. Bardia, I'd love to turn back to you and piggyback on some of the conversation Keegan was sharing about her own diagnosis. And a couple of questions that are coming up, I would say, are the efficacy around Trodelvy and, within the metastatic community, the Mets can go to different parts of the body, whether it's the bones, whether it's the chest wall lining, the organs, the brain, etc. Have you noticed any trends in how Trodelvy is positively working? Does it work better in one environment than the other?
Yeah, and a good question about impact of Trodelvy based on the site of disease. This is something we specifically looked at in ASCENT. We looked at patients who had visceral metastases, such as liver metastases, also looked at patients who had brain metastases. And essentially, you could see benefit with SG as compared to standard chemotherapy in all these sites. I think in part it is because of the antigen this targets. It targets TROP2, which is usually expressed in all tumor types in terms of where the tumor is. So that's why it's able to get there and give the toxic payload. So it does work in all those settings. Now, ASCENT trial did not allow patients with, say, leptomeningeal disease. So we don't have data of Trodelvy in someone who has leptomeningeal disease. Having said that, there is an ongoing study by SWOG specifically looking at Trodelvy in patients with brain metastases and leptomeningeal disease. So hopefully over time, we'll have some data about the efficacy in that subgroup.
Wonderful. And in your study, had anyone of the participants had a complete response while they were on Trodelvy?
Yes. And it's always wonderful to see a complete response. We had seen that in the phase 1, phase 2 trial, and we also saw it in ASCENT. And the numbers are not high. It's in single digits. For an individual patient, that's great news. We want to increase that proportion even further. And so moving forward, we are interested in developing combination therapy where we can combine Trodelvy with other agents, including other immunotherapy agents, targeted therapies, because we want to further increase the proportion of complete responses.
When someone has a complete response on Trodelvy, what happens next? Do they continue on with more cycles? Are they able to take a holiday or a break? Or do they go on to a different line of treatment? Tell me a little bit about what happens next when you see someone with a complete response.
Well, that's a very good question and something we discussed in the tumor board for a patient at our site who had a complete response a few years ago. And this was something that the nursing team brought up is, do we really need to continue? Can we, give a break? As was nicely mentioned before, it is an IV treatment. It's given 2 weeks on, 1 week off. Does have some side effects. I would emphasize it's not a drug that has zero side effects. It does have side effects, hair loss, decrease in counts, diarrhea. So for the patient, the question was, should we stop or continue? Once we got at least 2 scan results, I think there were actually 3 scan results, all of which showed complete responses. And this was around, I think, October, November. So we decided that with the holiday season coming up, we'll just stop and take a break and monitor the patient carefully. So the patient went off the drug. I think she remained off the drug for about a year or so. And then after that, we started to see that the lesions come back again. And we restarted the medication and were able to control it again. So it's a bit of a data-free zone. It's anecdotal, but I think for the right patient, if needed, a treatment holiday could be taken.
Yes. Oh, I love that term, treatment holiday. Janice or Keegan, have you had one of those, a treatment holiday yet?
I have not, but that sounds amazing to be able to get to a point where it's safe to do so.
And I've had a 5-year holiday.
That's wonderful.
Keeping our fingers crossed for you. It's amazing, yes. Especially with those response rates. And it's nice to know. I think sometimes in our minds when we meet people who are diagnosed with metastatic disease, I think we think lifelong we're going to be on treatment for the rest of our lives. And so I think it's also hopeful and inspiring to know that when you do respond well to these amazing chemotherapies and drugs and immunotherapies, that there is opportunities for some of these holidays. I remember looking at some pictures of myself thinking I was fine. I'm like, you get used to the fatigue, you get used to the joint pain. And I remember taking a holiday and I was like, oh gosh, I don't want to go back on. I forgot how good you can feel sometimes. But this allows me to segue into some of the conversations around side effects. So I want to talk a little bit to Keegan, if you want to express anything that you've experienced so far. How do you manage the side effects on Trodelvy?
I think my situation is a little bit different than someone just starting. I mentioned I had just done some radiation, and that radiation was a particularly harsh. It was proton beam, and according to both my medical oncologist and the radiation oncologist, they both told me multiple times it was a particularly intense treatment. It wasn't just your typical. So that caused a lot of side effects. And I started Trodelvy just coming out of that. So I believe some of the side effects from that were still present. Thankfully, I have not had a lot of bad side effects with the Trodelvy. The fatigue is the main one. I have, again, talking to others in support groups and forums and reading things, I've heard that GI issues were a big one for a lot of people. And thankfully, I haven't experienced too much of that. But, I'm assuming, this is very conversational. I'm going to speak freely. I
Absolutely.
hope it's
yes.
not too much for anyone. I did have a little tiny bit of an issue with diarrhea a couple of times and constipation. And those were, thankfully for me, fairly mild, over the counter things were able to help.
Great.
For me, it is on my second round of the cycle, I get Neulasta to help, for anyone who doesn't know, it's to help stimulate white blood cell growth. It's a on body is what I get. Some people get the shots. And so that can cause bone pain. And because of, there are some metastases to my bones, we just started doing Zometa as well, which is, it's given through the IV. I get it. I believe they're doing every 6 weeks at this point, and then they will lessen it to about every 3 months. And so this last weekend, I had pretty bad fatigue and bone pain. You just kind of deal with it. Everyone has their thing. For me, a heating pad helps when there's pain. I pretty much kind of leave my weekend after my IV. My infusion's kind of open because I don't know how I'm going to feel. And it's a little frustrating to have that uncertainty. But I kind of just leave, I don't make plans. If I get to do something, that's great. If not, I've kind of left it open. And, thankfully, I've actually been surprised a couple of the weekends. Like, did I actually get the treatment? Because I actually feel pretty good. So like, is something wrong here? No, I got it. I just lucked out. And then, as I mentioned, this last weekend was a harder one. I pretty much spent all of, for me, it's the weekend because I get treated on Thursday. So it takes usually about 2 days for the side effects to fully hit. So for me, I'm treated on Thursday. By Saturday, I can kind of feel the side effects coming along. And so I pretty much spent all of day Saturday in bed.
So it sounds like you're being very strategic with choosing your infusion days, clearing your calendar when you have those rounds. And are you still working at this time?
Yeah, I'm still working. I know some people are at different levels of, energy and all that. I'm grateful I'm still able to work. So I'm working. So Thursdays makes the most sense for me. I'm already off on the weekend. So Thursday is the only added day I need to take off. And I'm on pain management. I take extended release morphine once in the morning, once at night, just in general. Thankfully, that's usually enough for me, along with the pre-meds. Thank goodness for steroids. Thank goodness for anti-nausea medicine, because it is super helpful. Once in a while, I will have to take an extra pain medication. But, I'm really grateful, knock on wood. I don't want to jinx anything, but I haven't had really severe side effects. I know, I have experienced pretty much complete hair loss. These are drawn on eyebrows that you see. I have no hair on my head. I have maybe 10 eyelashes hanging on right now for dear life. But other than that, it's the fatigue and, some aches and pains, which I believe are probably caused more from the disease than the drug itself. But for me, it's been fatigue, once in a while, a little bit of digestion issues, but I'm very grateful there's nothing more intense than that.
Well, thank you for sharing that. And on Breast Cancer Conversations, there is nothing that is TMI. We are all in the same boat together. And I think it's helpful to talk about some of the stuff that other people don't want to talk about. That's why we're here.
Yeah.
So thank you.
I've definitely taken comfort in some groups. I've seen funny comments about how if you have a regular poop, it's a thing to celebrate. So
absolutely. And I'm glad you're finding ways to manage the side effects as well. Speaking of side effects, Dr. Bardia, what have you noticed in terms of your patients and the side effects, or perhaps through the ASCENT study? Are people able to decrease the dosage if they are unable to tolerate some of the side effects? And what is the efficacy when you do decrease?
Yeah, absolutely. We start with the dose at 10 milligram per kilogram. But for some patients, we do need to decrease the dose to 8 milligram per kilogram, sometimes even 6 milligram per kilogram. And that's usually because of side effects. And that could be either the counts are low, taking a long time to recover, or because of GI side effects. And we looked at patients who had a dose reduction in the ASCENT trial versus those who did not have a dose reduction. And in the ASCENT trial, we saw that the outcomes were pretty much similar in those who had dose reduction versus not. And I think it speaks to a specific individual. For some, a lower dose works very well. For others, a higher dose is needed. Keegan nicely mentioned the morphine. We know that for some patients, you need 10 milligrams of morphine. Others might need 30 milligrams of morphine. So everyone is a bit different, and particularly related to dose, you should titrate it to what works best for an individual. And that's the idea. You have to start somewhere, but then if you're running into side effects, I would feel very comfortable with lowering the dose.
Mm-hmm. And is that I think it depends on the individual, as you're mentioning too. So I'll just give an example. Let's say I am on this with 10 milligrams and I have a very terrible tolerance with everything and the side effects, and we decide to go down. And then we decide that there's progression. I'm just using a hypothetical example. Would we ever go back up and increase the dose?
Yeah, no, good question. I think it depends on the type of disease progression.
Mm-hmm.
So if someone is on 10, go down to 8, and patient does very well, down the road you see just some slight disease progression, one could consider going back to 10. On the other hand, if someone goes down to 8 and there is rapid disease progression with multiple new spots, then I would be more concerned about continuing with the same drug and would look at a different drug or a clinical trial in that setting.
That's a really good point. Exactly. So I think that's the science and the art around this disease, right? Is that, we need to really follow and understand why something is progressing, why something is working or potentially not working for the patient. And so all very good points in that discussion, and why it's so important to have those conversations with your oncologist and your medical care team to really make sure that it's tailored to your goals and quality of life. So thank you. What do you see on the horizon? What trends can we be excited about? I think you started to mention experimenting with Trodelvy in combination with other chemotherapies. What can we look forward to?
Yep, that's exactly correct. There are 3 broad things that I'm quite excited about. The first is building on the results seen from the ASCENT trial and looking at combination therapy of Trodelvy plus other agents such as pembrolizumab. And the sponsor recently announced that they would be doing a clinical trial looking at this combination for patients with metastatic breast cancer in the first-line setting. The second is moving this drug to early breast cancer to see if we can actually prevent metastatic breast cancer. So be it neoadjuvant or adjuvant, when someone is diagnosed with triple negative breast cancer, using the drug early at that time. And there are ongoing planned studies to look at that. And the third is newer agents that utilize this philosophy of antibody drug conjugates. We talked about TROP2 and Trodelvy as an example of TROP2 antibody drug conjugate, but there are other antigens that are overexpressed in triple negative breast cancer. And antibody drug conjugates that can target those antigens potentially could work in this setting. So I'm very excited about the field of these antibodies in general. I think they could make a big difference for our patients with triple negative breast cancer and breast cancer in general.
Wonderful. And I would love to stay in touch with you as well as you start recruiting any patients for these studies. There's probably a lot of outreach that we could do through survivingbreastcancer.org and let people know how they can get involved and follow the trends and be part of the solution.
That would be fantastic.
Wonderful. Keegan and Janice, maybe we'll start with you. My final question is there anything that I haven't asked that you would like to share with our listeners? I know this has been one of those conversations with so much information. I feel like I need to go back and re-listen to it myself. But what would you like to leave our listeners with?
I think we've covered the gamut, to be honest with you, as far as, what are we looking at in the pipeline? those who are diagnosed with metastatic triple negative breast cancer, it has such a poor prognosis. And I think, in order to offer hope for patients, just knowing that there is ongoing research and new clinical trials, combining drugs like Trodelvy with other agents that are already FDA approved. I think, finding other ADCs like in the same drug class that can target other antigens, because we just don't have, a real targetable disease. I don't think there's anything that we really haven't covered. I think one of the things, that as patients, we just always hope for more time.
Yes.
We want treatments that will extend our lives, and we want good quality of lives while we are living. And I think that's, one of the things that you will hear anybody who's diagnosed with any type of metastatic breast cancer say is that we just need more time. And as you all know, research takes often more time to develop a new treatment drug than what we have, with this disease. So I think you've done a great job, though, of covering so many things.
Keegan, what about you? Any key takeaways or topics that we haven't discussed that you would like to share with our listeners?
For the most part, I agree with Janice. I think we've covered a lot of really great things, and I hope it's educational to anyone who's either thinking about doing this drug or just about to start it. The one thing for patients, I know what's helped me, and I've been encouraged by, thankfully my doctors and nurses, is don't be afraid to be your own advocate. If your doctor has not ever mentioned this, ask about it. Tell them what you saw, like I heard about this. They maybe didn't mention it. Maybe they meant to mention it to you. And, I can't even imagine what the life of a medical oncologist is like, how many things are on their mind. Like, don't be afraid to ask. It just because they haven't brought it up doesn't mean it's not an option for you. Mm-hmm. That's really the only thing. And stay away from Google if you can, because as Janice said, it's real easy. We go out there and we look for hope and we look for encouragement. And Janice, your story is very encouraging. I'm so happy to have, met you on here as well as other groups. It's great to hear stories like that. But, a lot of this, as you said, it takes time to do this research. And so a lot of things are not published until much later. Mm-hmm. So the things that you'll find on Google are older a lot of times and not accurate. These statistics, I try not to read statistics, not to, the prognosis. I don't like that word at all. It's not accurate for every single person. And it's not really, it's not timely. That stuff was written a while ago about research and studies that were done even earlier than it was written. So, be your own advocate and just remember that if you do get in a Google hole and you're just trying to find everything you can, remember it's not always, specific to you, and it's not always up to date.
Oh, excellent advice. Dr. Bardia, I appreciate your time and so much appreciate you reaching out to our organization, sharing all of this information with us today and our listeners. And, I really just look forward to future collaboration with you. I think you're doing outstanding work, and I really appreciate you being able to share this information in digestible terms for all of us to understand and continue to sing the praises of the great work that's happening in the triple negative space. So thank you for joining us.
Yeah, thank you, Dr. Bardia.
It was a great discussion. I was very fortunate to be part of the panel. Thank you, everyone.
Thank you. And thank you all for listening and tuning in week after week here on Breast Cancer Conversations. Please be mindful that all of our content and information is for educational purposes only and is never a substitute for medical advice. If you want to hang out, again, please check out survivingbreastcancer.org/events, where you can RSVP to our Thursday Night Thrivers weekly meetup, our Movement Monday classes, workshops, seminars, and so much more. We can also continue the dialogue online via social media. Our Instagram handle is survivingbreastcancer.org, all one word, and you can follow us on Twitter at SBC_ORG. Until next time, keep on thriving.